So, first of all, thanks again for having us out, Brent and Amy. It's always fun to be here. And for those of you who saw the video on the humanitarian mission of Innovasis last night as well, I would just put in a plug for that too. If you ever thought about doing it, you should absolutely do it. And if you haven't thought about doing it, you should absolutely do it. It is why you got into medicine. It's the best part of everything we do. So, I gave this talk just a few weeks ago at an international conference for minimally invasive pediatric general surgeons, and they wanted the title Pediatric Tethering, which always makes me think of those kids running around in Disneyland with the backpacks. They've got the leash attached to it, but that's not what we're talking about today. And so when we're talking about what advances are we making in the pediatric world to avoid fusion, this is what we'll be talking about today. We'll try to trim a little bit of the fat to stay a little bit closer to time. For the neurosurgeons out there who maybe didn't study this too much, or for the guys who have been not around children very much lately in their practices, the Heuter-Volkmann law is what we're going to be taking advantage of here. This is the law that tells us that if we apply compression across a physis, we can actually slow the growth of that physis, or if we apply traction across the physis, we can enhance the growth of that physis. So in that way, we have the ability to control the rate at which a growth plate works, and we can do that differentially. So the best proof of concept for this is in lower extremity deformity surgery. You have a child with genu valgum, you can place a tether across the growth plate to enhance a compressive force. Of course, you see here, these are implants that do not cross a mobile segment. It simply crosses the physis, but you simply give it time. The lateral column continues to grow, the medial column does not, and you have wonderful deformity correction. The proof of concept for this in the spine was pioneered largely by Dr. Newton out in San Diego with bovine models, where he would take a straight bovine spine in a very young calf, place a stainless steel cable across some lateral vertebral body screws, and lo and behold, he could actually create scoliosis by inhibiting that growth pattern. Many of you probably saw early attempts at harnessing this Heuter-Volkmann law with vertebral body stapling. It was extremely limited, in my opinion, in its ability to encourage any change in the shape of the spine. It was limited in terms of the size of the curve that it could correct. And perhaps most importantly, it was a very static implant trying to cross a dynamic disc. So in my opinion, doomed to failure. It's been still limited, and I think it's going to see even decreased use as time goes by. So Larry Lenke in 2010 used lateral vertebral body screws connected to a polypropylene rope. I'm sure some of you have seen these in the dynamic systems that have been used elsewhere. So again, this is the use of a compressive force with a dynamic implant across a dynamic disc space in order to encourage the change in the shape of a spine. And he was able to show that with growth, this 40-degree curve went to a 25-degree curve. So this is what the older style implants looked like, or the concept. Here we have just very simple vertebral body screws placed laterally, and with care taken to, of course, think about the sagittal plane as well. If you're in the thoracic spine, you're going to place these slightly anterior. But then you have that polypropylene rope under tension, spanning the disc space. But what it's really doing is spanning the physis to encourage the lack of growth on the convex longer side. The real hope here is not only could we gain deformity correction, but we're also allowing for the sharing, and hopefully somewhat equal sharing, of loads across those disc spaces as the disc spaces remain normal, and perhaps we can avoid the troubles with adjacent segment degeneration. So further work by Newton also showed that with these compressive forces, not only did the discs maintain their shapes relatively well, but they maintained hydration, and that the shapes of the vertebral bodies actually changed. Now this is the key to maintenance, because if the rope can encourage a return to normal alignment, that's one thing, but that alignment would still only be maintained by the rope itself. If we can have actual remodeling of the shape of the vertebral bodies so that the sides are equal or closer to equal, then the maintenance of load could be much more easily maintained by the biology and the mechanics themselves rather than relying on the rope. Because I think the simple fact is the rope is going to break 100% of the time. So we've got to find a way to get the alignment where we need it to be, but it has to be through growth. It cannot be by the sheer mechanistic force of the rope itself. So indications for this, we have to have growth, and I will be the first to admit I was a little late getting to vertebral body tethering because I think the indications are tricky. Too much growth left, you're going to overcorrect. Not enough growth left, you're not going to get enough correction. If the curve is too small, you probably shouldn't be doing surgery anyway, but you're also going to overcorrect. And of course, we're trying to avoid unnecessary surgery here. If the curve is too large, you can't impart the forces that you need. That rope simply can't maintain it. It's going to break, and you've just wasted a thoracoscopic approach, and you're going to have to convert to fusion. So we have to be extremely narrow and extremely skeptical about the indications for this. My current indications, these are certainly going to become, I think, more narrow actually as time goes by, but I'll consider someone who's a current RISR 0, triradiate cartilage closed or closing, and a Sanders hand age of less than 4, curve sizes between 40 and 65. Again, that lower limit of 40 there that you see is based largely on these algorithms. If the curve isn't 40, in my opinion, we may never get to the point where we need to do surgery anyway. So why on earth would we try to correct that curve? If it's bigger than 65, I don't think we have the mechanics to correct it with that rope and with the Heuter-Volkmann law. I do this through a thoracoscopic approach, so the patients have to be able to tolerate single lung ventilation. We certainly do pre-op screening, but what it ultimately comes down to, and I tell the parents this every single time, you don't know if your child can tolerate single lung ventilation until they're under single lung ventilation. We initially did this with 2 lumen tubes going into the right and left main stem bronchus, but now actually our anesthesiologists have gotten very good at simply insufflating a little bit of CO2 into the chest. We can keep the lung on the side that we're operating on relatively inflated, and it actually makes it very easy to oxygenate these patients. So we haven't had a single failure due to that. I add ketamine, which is something that I don't usually do with my posterior spinal fusions, but it acts as a small bit of a bronchodilator as well and helps us with the oxygenation. I talk with the families a lot. You will never become more of a Facebook villain or hero as you will when you start doing vertebral body tethering. The Facebook groups are incredible. They know how many patients you've done, your average blood loss, your curve after the correction, how many tethers have failed. They know everything. They know my stuff more than I know my stuff. So you have to counsel them thoroughly, and one of the things that I counsel them on a lot is rotation. Vertebral body tethering does not correct rotation very well. So if they have a big issue with cosmesis, a large thoracic rib hump, VBT is not for them. And they will still want it, but I still tell them it will not correct that very well. T4 is about as high as I can go with the current instrumentation. L4 is about as low as I can go with the current instrumentation. But the truth is, I will work as hard as I can for a lumbar VBT because I think that's where the big ultimate payoff is going to be. If we can get lumbar curves to correct and avoid fusion in the lumbar spine, then I think we're going to be very happy with this. So just a quick look at how this is done in my operating room. They're placed in the lateral decubitus position with the convexity superior or pointed toward the ceiling. I create bolsters that give me a gap so that as I place the tether and tension it, I can push down on the apex of the convexity and get as much correction as I can right there on the table. So I'll usually be pressing down on the screw, tensioning the tether, and having my assistant place set screws and things like that. So hopefully we'll develop ways to position that a little more easily in the future, but we'll see. After the chilly reception of the arthroscopic videos yesterday, I was a little hesitant to show these. Can you guys see the L5 nerve root in there? So this is obviously, for example, their typical apex right thoracic curve, we're usually going to go from about T5 down to anywhere from T11 to L1. We can easily get to L2 through the thoracoscopic approach. We just sweep the diaphragm down a little bit and it's quite accessible. Average number of incisions, I need a 15 millimeter portal to get my instrumentation in. And so if we go from T4 to L1, 4 incisions. So we take down the segmental arteries. I actually am trying to find a way to obviate that portion of the procedure as well, just because it makes me nervous, even though we've never had an intraoperative nerve monitoring alert or loss of motors, taking down all those segmentals at multiple areas, especially if I need to instrument bilaterally at any of the segments, makes me very nervous. But my thoracoscopic surgeons help us with the approach. You have to be ready to plan in order to minimize the number of incisions. You have to know where that curve is going to be. You have to make your incisions very posterior because of the large amount of rotation at the apex. You have to have an idea. I can usually get about 3 vertebral bodies per incision. And so you just have to know where the apex is going to be, the largest splay that you're going to get, and try to minimize the number of incisions that you're going to make. Yep, so, oops, sorry. Yeah, so, say that one more time, sorry. Yes, and so, first of all, if I go bilateral anywhere, I do not take down the segmental. So for example, if I have a double curve, and I'll show an example of that in just a little bit, then I will actually place one screw above the segmental on the right side and one below the segmental on the left side. I've been in institutions where they'll also run motors before and after taking the segmental. I don't do that because I figure I just took the segmental. So we're working as hard as we can. As you work lower in the thoracic spine, at least in my experience, the segmentals actually move distally just a little bit, and so we've been working harder at not taking them in those areas.
I don't think it's an issue, but I'm asking what they're doing.
Well, I haven't seen it be an issue, but I don't want it to be.
I don't think taking the segmentals, because a lot of that spinal cord comes from the vascular CT bypass. I don't think taking the segmentals here, as many as you want, I think there's too much consequences taking the spinal cord. You go to the multiple spinal cord,
Mm-hmm.
even left side, T8 to T7, L2, and all of them, never had an issue. And like I said, wasn't going to be
Yeah.
temporary.
Right, which I find to be kind of a waste of time, but yeah, yes. Yeah, and I think that's a good idea. The trouble with that for me is the time that it takes. I honestly don't know how many minutes is it going to take me, occluding that, until I find whether it's going to make a difference or not. Mm-hmm. Only because when I do bilateral, it's usually at those lower thoracic segments where there may be a little bit of crossover. Again, it's probably me being a little more paranoid than I need to be, but just that's, especially early on in this experience, that's just the way I wanted it to be. Yeah. But for any of you who do a lot of arthroscopic surgery, I'll tell you, thoracoscopic surgery, that is the biggest space you will ever operate in your life. It's like a big old playground. It's great. You'll also notice that in my case, it's a pediatric general surgeon who helps me with the thoracoscopic approach. You'll see in all these videos, he never looks directly at my instrumentation. He always keeps it centered so that I see the lung on one side and what I'm doing on the other. I think it's his subtle way of saying stay away from that lung. But this is what it looks like as you move forward. So there's a starter awl. I do all of this freehand, and then I do an O-arm spin at the end to try to reduce radiation exposure to my team. Although, yes, that absolutely exposes my patient to a significant amount of radiation anyway. There is newer instrumentation now that this has been recently FDA approved that allows us to do this with a little more facility so that we can line up our starter awl, our taps, get accurate measurements, and then place our screws. This is the polypropylene rope that you see going in. Again, the instrumentation is reasonably good, although there's an incredible amount of improvement that could be made. Once all the screws are in, I'll start at the most cephalad segment. The farther away I am from the apex, the less tension I impart onto that rope, just because we've seen that at the more distal and caudal, or the more caudal and cephalad segments, if you tension too much, you overcorrect far too easily, whereas at the apex, more tension is to your advantage. Now, those are purposely nebulous statements because there is zero literature to guide us on just how much tension we're supposed to get here, or how much correction we're supposed to get with a certain curve size with a certain amount of growth remaining, and how that's going to lead us to success. So again, indications are going to be huge as we continue through this process, and trying to figure out, my guess would be it'll require some sort of wonderful AI algorithm that allows us to understand this much better. So for my first 10 cases, I did an O-arm spin at the end so that I could check my screw placement, the length, everything, to make sure that I was orienting as well as I thought I was. There are 2 outcome studies. They're both short-term, of course, right now. One out of San Diego and one out of the Philadelphia Shriners Hospital. Vastly different conclusions, where there were very few complications and great results in Philadelphia. There were okay results, but a very high complication rate in San Diego. Those numbers, you see n equals 11 and n equals 17, those numbers are already significantly higher. It's just that with the recent FDA approval of all of this, much of what they've been able to prospectively collect so far has not been presentable. So I need to update this slide. We're on case number 12 currently. Average inpatient stay is 3.5 days. We usually have a chest tube in for a couple of days. 0 intraoperative nerve monitoring alerts, no infections. I let them go back to activities at 6 weeks. We had 1 state champion gymnast 6 months post-op. But of course, this follow-up is well too short. Average OR time, now that we've done several of these, skin to skin is a little less than 2 hours. Blood loss is usually around 25 to 40 cc's. So here's an example that I was telling you about, a young lady with a progressive curve who had been bracing. She had gone through multiple chiropractic care protocols, physical therapy, all of those things, and was continuing to progress. We did a bilateral tether on her, and again, these lumbar and thoracolumbar curves are the ones that I'm most optimistic will get good correction and good outcomes from this. This is our gymnast. So this was her pre-op study immediately prior to surgery, and that was her at 4 months. You can see Risser scores are just starting, or her Risser sign is just starting to show up there. So very short-term data, of course. We can't really draw any reasonable conclusions from any of this yet. But so far, what I would express to you is that I think it's a safe thing to do currently. Revising these to posterior spinal fusions is actually a very simple thing to do if we need to. But I think the potential for this, especially in thoracolumbar and lumbar spine scoliosis, to hopefully obviate fusions and adjacent segment degeneration is very promising. Thanks.